Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sejahtera bagi kita semua. Om Swastiastu, Namo Buddhaya, salam kebajikan. Yang terhormat Rektor Universitas Hasanuddin yang pada kesempatan kali ini diwakili oleh WR2 Prof. Insinyur Sumbangan Baja MPhil PhD. Yang terhormat Ketua Kolegium Anestesiologi dan Terapi Intensif Indonesia, Profesor Nancy Margareta Rehata. Yang kami hormati Bapak Dekan Fakultas Kedokteran Universitas Hasanuddin, yang kami hormati Ketua Departemen Ilmu Anestesiologi, Perawatan Intensif dan Manajemen Nyeri, Profesor Safruddin Gaus, yang kami muliakan dan kami hormati para guru-guru besar yang mengikuti acara ini. Yang kami muliakan juga para pembicara kita pada hari ini, yaitu Profesor Frederick Fuhringer. Beliau adalah Ketua Departemen Anestesiologi dan Perawatan Intensif Klinikum Ensteinenberg, Rettlingen, Germany. Juga Claire Rogues, merupakan konsultan anestesi dan manajemen nyeri dari Royal College of Anesthetics, Pain Management Committee of World Federation Society of Anesthesiology, and also has joined us in this meeting. Welcome to Surapong Larsomradi, Associate Professor Cardiac Anesthesiologist from Chiang Mai University Hospital, Thailand. Juga tentunya kepada Ketua Panitia yang telah sukses menyelenggarakan kegiatan ini, Dr. Andi Muhammad Takdir Musbah, sekaligus sebagai Ketua Program Studi Anestesiologi, Terapi Intensif dan Manajemen Nyeri, FK Unhas. Selamat siang dan salam sejahtera. Pertama-tama marilah kita mengucapkan rasa syukur sebesar-besarnya kepada Tuhan Yang Maha Esa yang telah memberikan kita kesempatan untuk menghadiri kegiatan ilmiah pada hari ini meskipun dengan secara virtual. Hadirin sekalian, pandemi bukanlah alasan bagi kita untuk tidak menimba ilmu dan jarak bukanlah hambatan bagi kita untuk tetap selalu belajar. Karena itu, Universitas Hasanuddin, khususnya Departemen Ilmu Anestesiologi, menyelenggarakan International Webinar in Anesthesiology, Learning Together, We Working Together, and We Sharing Each Other, dalam rangka memperingati Dies Natalis Unhas ke-65 sekaligus hari jadi Departemen Ilmu Anestesiologi yang ke-25. Adapun rangkaian acara kita pada hari ini berupa pemaparan materi yang akan dibawakan oleh para pembicara kita yang telah saya sebutkan sebelumnya. Untuk itu, marilah kita melangkah ke acara yang pertama, yaitu acara sambutan. Pada kesempatan pertama ini, kami berikan kesempatan kepada Ketua Departemen Ilmu Anestesiologi, Fakultas Kedokteran Universitas Hasanuddin, kepada Dr. Safruddin Gaus. Kami persilahkan. Masih mute, Dok?
Terima kasih, Dr. Eka, sebagai moderator. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera buat kita semua. Yang terhormat Rektor Universitas Hasanuddin yang dalam hal ini diwakili oleh Wakil Rektor 2 bidang Perencanaan Keuangan dan Infrastruktur, Profesor Insinyur Sumbangan Baja MPhil PhD, Ketua Kolegium Terapi Anestesiologi dan Terapi Intensif, Profesor Nancy Margareta Rehata yang lebih populer kita sebut Profesor Rita, juga yang terhormat dekan kita, Profesor Dr. Budu. Terima kasih banyak atas kesempatan waktunya dan dapat meluangkan waktunya untuk menghadiri webinar ini. Juga kepada Prof. Husni, Prof. Ramli, senior-senior saya dari Departemen Ilmu Anestesi, para alumni dan para stafnya. Webinar ini merupakan rangkaian dari Dies Natalis yang kita buat Dies Natalis Unhas yang ke-65 dan sekaligus 25 tahun program pendidikan spesialis anestesiologi dan terapi intensif. Jadi kita tahu bahwa pertama kali memulai pendidikan spesialis anestesi itu di Unhas adalah 1996, di mana presiden pertama itu saya sendiri dengan Prof. Sapri. Setelah itu akan berkembang. Jadi ada beberapa rangkaian acara dalam rangka ulang tahun kita, yaitu salah satunya adalah webinar ini, kedua adalah pembuatan buku dan lain-lain, dan rencananya juga ada.
Mohon maaf dok, termute lagi dok.
Untuk para pembicara dari luar negeri, greeting from Makassar, especially for Profesor Friedrich Pullinger, Dr. Claire Roach, dan Profesor Surapong Larsom Radi. I thank you very much for being a speaker and sharing knowledge and experience in dealing with patients in operation room, intensive care unit, and emergency department. Hopefully, the knowledge gained today can be useful for all of us. Maybe we are always in the protection of God Almighty and always good in good health. Terima kasih atas waktunya, dan saya ucapkan selamat berwebinar. Mudah-mudahan ilmu yang kita dapat hari ini dapat bermanfaat untuk pelayanan anestesi pada masa yang akan datang. Sekian. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dr. Safruddin Gaus untuk sambutannya. Selanjutnya kesempatan kedua kami berikan kepada Ketua Kolegium Anestesiologi dan Perawatan Intensif Indonesia, Profesor Nancy Margarita Rehata. Kepada Prof. Rita, waktu dan tempat kami persilahkan.
Terima kasih Dr. Haisa. Salam dan selamat siang untuk semua para hadirin. Yang terhormat Bapak Rektor Universitas Hasanuddin, dalam hal ini diwakili oleh Prof. Sumbangan Baja, mohon maaf kalau salah ngomongnya Prof, sebagai waktu rektor 2. Yang terhormat Prof. Budu, Ketua, tidak Ketua lagi Prof, dalam hal ini sebagai Dekan Fakultas Kedokteran UNER, juga kepada Dr. Syaifuddin guys. Sudah profesor ya, Dr. Syaifuddin, maaf Profesor.
Belum salah. Moderator salah sebut.
Tidak apa-apa, berarti didoakan. Doakan. Secepatnya Pak Rektor dibantu. Yeah. Kemudian juga guru-guru saya, Prof. Husni terutama, dan para guru besar lain, Prof. Ramli, dan para anak didik yang sudah jadi gede, Dr. Takdir dan tim semuanya, termasuk Dr. Haisa, yang selama ini dekat-dekat sekali dengan saya, Dr. Haisa, ya, selalu bertemu. Pertama-tama bersyukur bahwa pada hari ini kita semua dalam keadaan sehat walafiat dan dapat menghadiri acara yang luar biasa ini, yang juga termasuk dalam rangkaian Dies Natalis ya, Dr. Syaifuddin Gaus.
Ya, Prof. Ya, Prof.
And because it is an international webinar, allow me to say something to our guest speaker. On behalf of College of Anesthesiology Indonesia, we will extend our gratitude and thank you that you will join us in the special event of University of Hasanuddin Anesthesiology Department. Maybe one day, beyond the pandemic, just come and join us in reality. Thank you, and juga kepada para hadirin yang lain, selamat untuk dapat bersama-sama dengan Departemen Anestesiologi dan Terapi Intensif Universitas Hasanuddin dapat merayakan 25 tahun ulang tahun ini. Sebenarnya Dr. Syaifuddin Gaus, saya mempunyai kisah yang spesial dengan Has, karena kalau Prof. Hasanuddin, Prof. masih ingat,
nanti saya mampir sedikit.
Halo, kalau Prof. Husni masih ingat, saya juga ikut visitasi loh waktu mau dibuka. Dan waktu itu Prof. Husni masih kepala departemen, dan saya berbahagia saya menjadi orang pertama yang datang ke Unhas waktu belum mulai untuk persiapan, dan waktu itu kolegium juga harus melihat visitasi, dan saya bersama waktu itu Prof. Edi yang ke sini dan melihat, dan Prof. Husni yang menerima kami. Jadi alhamdulillah setelah 25 tahun sudah jadi besar amat dan akan menjadi terus berkembang dan sukses, itu doa kami semua, dan menjadi panutan untuk anestesiologi dan terapi intensif di Indonesia. Mudah-mudahan webinar internasional ini membawa sesuatu yang positif, ilmu, dan semua hal yang bisa kita dapatkan dari para expert dari luar negeri. Sekali lagi sebenarnya harus selamat pada Prof. Husni juga, karena beliau yang mulai membuka dan berjuang untuk menjalankan, dan untuk Dr. Syafruddin Gaus, karena estafet sekarang pada Dr. Syafruddin untuk berlari lagi ke depan dan membuat makin hebat. Sebagai ketua kolegium Dr. Budu, Prof. Budu, saya titip supaya dibelain bahasa Indonesianya, dibesarkan departemennya ini, dan untuk Prof. Wakil Rektor 2, cepatkan Prof. Dr. Gaus jadi profesor. Anestesi butuh profesor di Indonesia. Kita kehabisan profesor yang aktif. Dan kita perlu untuk membina generasi yang berikutnya. Mudah-mudahan doa ini dapat diterima dan diberikan jalan untuk mendapatkan apa yang kita cita-citakan.
Amin.
Amin. Terima kasih, dan saya kembalikan kepada Dr. Haisa.
Baik, terima kasih Prof. Rita untuk sambutan, juga beberapa harapan dan doanya. Semoga dikabulkan segera oleh Allah Subhanahu wa Ta'ala. Terima kasih, Prof. Dan selanjutnya kita melangkah ke sambutan yang ketiga, yaitu dari WR2, Bapak WR2, Prof. Insinyur Sumbangan Baja, MPhil, PhD. Kepada Prof. Sumbangan Baja, waktu dan tempat kami persilahkan.
Halo, baik. Bisa dengar suara saya?
Bisa, Prof. Terdengar jelas, Prof. Ya.
Assalamualaikum warahmatullahi wabarakatuh, and good morning and good evening for everybody. The Honorable Dean, the Faculty of Medicine, Hasanuddin University, Head of Department of Anesthesiology, Faculty of Medicine, Hasanuddin University, Bapak Dr. Syafruddin Gaus, the Honorable Professor Nancy Margarita Rehata, Professor Rita, for the Indonesian College of Anesthesiology and Intensive Therapy. Distinguished speakers, we have, I think, 3 speakers: Professor Friedrich Buchringer, Professor and Chairman, Department of Anesthesiology and Intensive Care Medicine, Klinikum at Steinberg, Reutten, Germany. Claire Roquis, MD, PhD, Consultant in Anesthesia and Pain Management, Academic Interest in Global Pain Management, National Healthcare, University of Cambridge, United Kingdom. And Associate Professor, Dr. Surapong Lorsomrade, Associate Professor, Faculty of Medicine, Chiang Mai University, Thailand. Distinguished guests, college, ladies and gentlemen. First of all, I would like to congratulate the Department of Anesthesiology, Faculty of Medicine, Hasanuddin University, for its age of, I think, 25.
Yeah.
Yeah, and also the age of 65 for the Hasanuddin University. I am very pleased to welcome you to this webinar on, I think the topic is update in anesthesiology. This is the series number 3, I think. This seminar has been very well organized by the Department of Anesthesiology, Faculty of Medicine, Hasanuddin University. A glance through the schedule plan for the webinar reveals that very amazing topics on anesthesiology area to be discussed today. And I think this is very important for us in the Hasan University, especially for our student and also our lecturer. Of course, these topics will give very much contribution to our curricula, I think, particularly in the Department of Anesthesiology, in the Faculty of Medicine, and also for our research topic in the area of anesthesiology. Ladies and gentlemen, I would like to give you some information about Faculty of Medicine, and also actually we have a teaching hospital also in this university. Faculty of Medicine is one of 16 faculties in Hasanuddin University, and while anesthesiology is one of the departments in the Faculty of Medicine. And today is its 25th anniversary. This faculty has shown itself a very fast growth in terms of a number of students, number of international events, and also we have some also international students in this faculty. And very important is the output from research activity from its professor, quite a lot coming from this faculty, especially also from this department. We are very happy with the achievement of this faculty and this department in terms of fulfilling our three missions of higher education: research, community service, and also education. To support academic activity in this university, we have also established a university teaching hospital. We call here Rumah Sakit Pendidikan. I think the director is with us today, Professor Sapri. And this hospital has provided service to student activity, for academic activity, and also service for the community around. And this teaching university is very big development recently, and the hospital become a very important laboratory for the student and lecturer from the university, especially from this faculty. Promoting research activity has become the focus also of the university program today. Faculties are encouraged to hold international events like this, and I think this is very good international event like this, especially for the webinar. And we invite very prominent speakers coming from different university. This year, Hasanuddin University has a program around 20 webinar or 20 seminar, international seminar from different fields of study. And I think today is one of very important one in the area of anesthesiology. And we also have quite a lot of budget for that, supporting to hold the international event like this. In terms of promoting our research, we also run some program like inbound and outbound lecture, and also student from this university. We also receive quite a lot international student doing a research in this university. The key point of such program is to strengthening our network between of course, scientific community between UNHAS, Hasanuddin University, with and our partnership university abroad. Ladies and gentlemen, of course, conference such as this provide a valuable opportunity for students, lecturers, research scientists, and also I think industry specialists and decision makers to share experience. I'm very grateful to the many students who has joined this webinar today to discuss some, I think, very interesting topic from our prominent speakers. I also welcome the industry association and lecturer and postgraduate student, I think, who have joined this symposium. I'm very sure that you will have a fruitful and rewarding exchange during this webinar. I wish you every success with this webinar, and we look forward to learning about the outcome, of course, of this discussion. And once again, I would like to thank the head of Department of Anesthesiology, the Dean, organizing committee that have organized this very well event, this webinar. And for our prominent speaker also, I'd like to thank on behalf of the rector of the university. Thank you very much for your time. You have spent your time to provide, to share your experience, and also I think a lot of information about this area that we can share and listen today. Enjoy your seminar, enjoy your discussion, and thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Yeah, thank you, Professor Sumbangan Baja, who has spared his valuable time to open our webinar today. Terima kasih, Prof. Dan demikian sambutan yang ketiga dari Profesor Sumbangan Baja telah menutup acara kita pada sesi pertama ini, dan selanjutnya kita akan melangkah ke sesi kedua, yaitu sesi ilmiah. Namun sebelum kita melangkah ke sesi ilmiah, kita akan mengikuti terlebih dahulu pemutaran video kolase kegiatan pendidikan di Departemen Ilmu Anestesia. Kepada admin kami persilahkan untuk dapat memutarkan video. kegiatan mulai dari sejarah hingga kegiatan-kegiatan yang dilakukan di Departemen Ilmu Anestesi. Selanjutnya kita akan melangkah ke acara berikutnya, yaitu sesi ilmiah, merupakan sesi kedua dari acara kita pada siang hari ini, di mana sesi ilmiah akan dibawakan oleh beberapa pemaparan materi yang akan dibawakan oleh para speaker yang telah disebutkan sebelumnya. Untuk itu, saya serahkan acara ini kepada moderator kita yang akan memimpin acara kita selanjutnya. Kepada Dr. Takdir, kami persilahkan.
Dr. Eca, bisa kami live pertemuannya. Makasih ya, Dr. Eca.
Siap, Prof.
Ya,
siap, Prof. Budut.
Ya, Prof. Ya, persumbangan Prof. Ramli, Pak Ketua Bagian, Dr. Takdir. Terima kasih. Assalamualaikum.
Waalaikumsalam.
Mohon maaf, masih mute.
Okay. Thanks, Dr. Haisa, for the time to lead the webinar scientific session. First of all, I would like to say thanks to the committee to give me a chance to be a moderator for this. I think this will be a very informative webinar for all of us here. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Good evening for everyone, professor and doctor who has joined to this webinar. I hope that you all in a good condition during this pandemic era and still always stay health and stay safety in your life and in daily activity. So welcome to the international webinar of anesthesiologists conducted by Department of Anesthesiology, Intensive Therapy and Pain Management, Faculty of Medicine, Hasanuddin University. And it is a collaboration with the Indonesian Association of Anesthesiology and Intensive Therapy. So this webinar is a part of the series webinar. It's in commemoration of 25th anniversary of the specialist program of anesthesiology and intensive therapy of Faculty Medicine and Hasanuddin University. So the topic of this webinar today is about update in anesthesiology. If we talk about the updating, of course, we know that as anesthesiologists, also as a medical practitioner, we know that medical science, medical technology is still ongoing time by time. And I think that we need to update our knowledge. We need to looking for some new information, some new issue that we need it to be known, because all of the development in medical science is intended to provide excellent service. So I mean that if we are a doctor or institution cannot be follow and adapted with the changing, maybe we cannot be provide better and excellent service for our patients. And anesthesiologists work in three big domains. Is perioperative anesthesia. We have domain in intensive and critical care, and also in pain management. These three big domains need to be known more and more, and there is a medical development at in this domain. So today, Department of Anesthesiology, Intensive Therapy and Pain Management, Faculty of Medicine, Hasanuddin University, make an international webinar about updating in anesthesiology. So we are very lucky and very honored because we have three distinct speakers from three different countries. Professor Puringer from Germany, Dr. Claire Rose from UK, and Dr. Surapong from Thailand. So they will give us many information, I think. They are an expert in their file, so they can give us the information. They can share their expertise and their knowledge about the domain in anesthesiology. So I think this is the very good opportunity for all of us in here as a medical student, as a residential student in anesthesia, and of course for all of us in anesthesiologists and the lecturers in the Department of Anesthesia. So I would like to say thanks to all the speakers who can give us a time to participate in this international webinar. So as information for all of us in here, for the participant, that after the three speakers present their talk, we have a time for discussion session. I think this is the very important session in this webinar, because we can ask, we can share and discussion about the point that we get from this webinar. So we have 30 minutes, and if you have any question or if you have any comment, you can write it in the chat box in your screen, in your Zoom or in a YouTube channel. So we can discuss later after the third speaker has presented his talk. So for the efficient of time, I would like to start with the first speaker. I would like to introduce the first speaker for this webinar today. This is Professor Friedrich Furinger from Germany.
Okay, can I start?
Wait a moment, please, Professor. So Professor Friedrich Furinger is a professor and chairman of Department of Anesthesiology and Intensive Care Medicine, Emergency Medicine, Pain Therapy and Palliative Care, Kreiskliniken Rehlingen Academic Hospital, University of Tübingen, Rehlingen, Germany. So Professor Furinger, you have 30 minutes for your presentation. I think time is yours now. Please, Professor Furinger.
Okay, so good morning or good day to everybody, and thanks a lot for giving me the pleasure of being part of this international symposium. So it's a great honor for me being invited by Hasadan University. I hope everything is working fine. Well, when we talk about modern anesthesia, the question is always, what do we focus on? And we have to talk about predictable drugs which provide fast onset and fast offset. They should have low or no metabolism, and they should be reliable. And when I mean reliable, I mean that they are unaffected by age, by body composition, gender, or any organ dysfunctions. When I talk about predictability and reliability as well, I would like to have a constant duration of action, and I want fast recovery of action, because this is so important in terms of quality of recovery, because we want to have the fast return of airway reflexes to protect our body. We do not want to have any impairment of any ventilation post-operatively, and there shouldn't be any impairment of cognitive function. We do know that the elderly especially suffer from delirium, and outcome of operation and of hospital stay is dramatically reduced when they go into delirium and they have an impaired cognitive function. So the danger is that the patients are coming in with preconditions like sleep apnea, with like obesity, hypoventilation. So they have already impaired ventilatory responses. If we add on that residual neuromuscular block or residual volatile or IV anesthetic effects and the effects of opioids and probably inadequate postoperative observation, this all sums up into respiratory arrest and damage and danger for the patient. So this is why we have to focus on parts of this. I mean, we can't change the preconditions, but of course we can have a close look at residual neuromuscular block or at residual volatile or IV anesthetic effects. So when we look at residual effects of volatile anesthetics or IV anesthetics, we have to focus, first of all, on the effects of not being properly awake at the end of anesthesia. And this data is already from 1991, so they are 30 years old. They clearly show, this is like where the group 1 is. The different colored bars means the age group. So green is elderly patients above the age of 70. And one means that these people were fully awake at the end of anesthesia. And you see, when people are fully awake at the end of anesthesia, there is a very, very low risk of suffering of respiratory complications post-operatively. Group T2 represents the patients who have been only awake upon verbal stimulation. And you see the increase, especially in the elderly, is dramatically receiving postoperative pulmonary complication when they are just awake to verbal stimulation. And as you can see, the group 3, they were only awake upon physical stimulation. So even the mid-agers between 50 and 70 immediately went up with the risk of pulmonary complications. And group 4 represents the patients who have not been awake at all, who were unconscious. Those kind of, oh, they woke up and they were so calm and they were really nice waking up. Those are the patients who having, like in the elderly, a 10 times higher risk of postoperative pulmonary complications compared to those who were fully awake without any stimulation. So these data are already 30 years old. And the question is always, did we focus on that? Did we ignore that? Or what happened? And this is why it's so important that we look about the kinetics of onset of volatile anesthetics. And we all know that the low solubility of nitrous oxides provides a fast onset and a fast offset of that drug. And almost as fast is desflurane. Whereas all the gases with a higher solubility, like sevoflurane, who represent like a cerebral uptake of 80% only within 15 minutes, whereas it takes only 2 minutes for desflurane and about 1 minute for nitrous oxide. The low solubility is a huge advantage in terms of predictability and reliability of onset and of offset of drugs. And then when we look at the terminal decrementation, the elimination time of volatile anesthetics, you see with desflurane, no matter how long you apply this drug, there is always a fast elimination. This is due to low solubility. The body, it releases the gas immediately. There is no storage in any of our compartments. And this is so important, whereas there is accumulative effects and a prolonged elimination in sevoflurane, in isoflurane, and enflurane. So these are the old slow gases. And these are the ones who keep the patients inside, and it provokes the prolonged wake-up period. And this is all endangering our recovery of the patient. When we look at the diffusion coefficients, and diffusion coefficients represent elimination time from one compartment to the other compartment, the lower the diffusion coefficient is, the faster the patient gets rid of the gas. And when we see, like from the last line, from fat to blood, it's 27 for desflurane, it's 45 for isoflurane, it's 48 for sevoflurane. So dramatically less for desflurane. That means faster release out of obesity compartments. But you see, isoflurane is even faster than sevoflurane. If we look from brain to blood, which is in the third lane, 1.6 compared to 1.3 and 1.7. Again, desflurane dramatically faster than sevo and isoflurane. And the last step, from blood into the alveoli, 0.42, 0.69, 1.4. This is the only compartment where isoflurane is slower than sevoflurane, but again, dramatically faster for desflurane. So the low solubility of desflurane is a great advantage in terms of elimination of the gas. And this is what I already showed in the previous slide, that no matter how long you're using desflurane, you always can rely and predict a fast recovery. Low solubility means we need high concentrations to get the gas into the body, into the patient. And this is why desflurane has a MAC value of around 6% compared to 2% for sevo and 1% for isoflurane. When we look at elimination times and wash out and wash in curves, and of course, wash in desflurane is faster in morbidly obese patients compared to sevoflurane, but this is clinically irrelevant because we usually induce with IV drugs. But when we look at washout curves, even in morbidly obese patients, as on the right scale, you can see within 1 minute only, 80% of desurain is washed out of the body. 80% of the whole gas is eliminated within 1 minute, compared to 5, 7, or 10 minutes for sevoflurane or isoflurane. And this is the predictability I'm asking for, because we need to have our patients brilliantly awake at the end of anesthesia. And when we are going into that direction, I would like to show you those data, clearly showing there is a difference in terms of eye-opening compared in morbidly obese patients when we compare sevoflurane, which are the yellow bars, compared to desflurane. This is like 7 minutes compared to 11.7 minutes. It's a difference of 4.5 minutes in eye-opening. But what I would like to draw attention to is, look, stating the name, the difference already increases from 4.5 minutes to 7 minutes. And if we compare the data in terms of stating date of birth, this 4.5 minutes to 7 minutes even extends to 10 minutes. And this is the thing. When people are waking up after desflurane, they are brilliantly awake. And the difference is getting bigger and bigger in terms of quality-related data. And eye-opening is an easy thing, but stating date of birth is something really, really complex for the patient. And the quality recovery is what we need, because patients need to protect their airway, and they need to be safe in terms of post-operative vital function. And the same situation is when we compare, which are the green bars, compared to propofol. There is a lot of people around the world telling us that TIVA is so beautiful and so nice. The thing is, in some patients it is, we do know, but predictability means in all patients. And we do know that especially in the elderly, there is some context-sensitive half-life prolongation for propofol. And this is what you can see in this slide as well, that there is a huge difference in terms of desflurane compared to TIVA in wake-up criteria. Because in some patients, TIVA patients are waking up brilliantly. We all know that from our daily clinical practice. But in some patients, we do know that they don't wake up. We wait because of those cumulative effects in some of the patients in terms of TIVA. Very interestingly, already in 21 years ago, Pierre Chauvin, at the end of one of his investigations on desflurane compared to TIVA and SIVO, he said, he stated in his paper that there was less hypoxemia with desflurane at the time of arrival in the post-anesthesia care unit. And he couldn't explain the phenomenon at that time, because he just saw that when he delivered patients out of the operation room into the PACU, arriving there, they had better saturation values compared to the other groups. But this was not a part of that investigation, but I will come back to that phenomenon later, because now 21 years later, I can show you the reason and the explanation for this phenomenon, that patients after desflurane anesthesia have less hypoxemia post-operatively. Well, when we talk about predictability, it's not only about time, that they are waking up faster, because this is one point, but the most important point for us as anesthetists is patient safety. And this is why I would like to draw attention on patient safety so dramatically. This is a paper presented by Rachel Eshima McKay from San Francisco, and she was looking at young and healthy ASA1 and ASA2 patients undergoing laparoscopic surgery, laparoscopic cholecystectomy. And the aim of this study was that patients were waking up, they had to respond proper to commands, and when they proper responded to commands, like they were shaking hands, opening eyes, showing the tongue, then this study started. And they compared SIVO to desflurane. And of course, it was faster achieved that point for desflurane, but this didn't count. They wanted them, when they were proper responding to command, to drink 20 mils of water. And what did she find? She found that 2 minutes after proper responding to commands, all desflurane patients were able to swallow properly 20 mils of water without drowning or coughing or aspirating. Whereas from these young and healthy patients, less than 50% were able to swallow properly. And it took up to 14 minutes that all SIBO patients were able to swallow properly. Young and healthy people, less than 50%, even responding proper to commands, were able to swallow. They were guggling and coughing, and even some of them were aspirating. So the same setup she did a few years later again, but she was looking at people with an increased body mass index, and she was looking about the effect of anesthesia duration time. And what did she find? Well, the black dots are responding the return of airway reflexes after sevoflurane, and the white triangles are the return of airway reflexes after desflurane anesthesia. And look at the distribution of the dots. And on the x-axis, you can see the body mass index. So you see, no matter if you have a BMI of 20, 25, 30, 35, or 40, after desflurane, there is a narrow corridor when the airway reflexes are returning. So the predictability is high and the quality of recovery is high. Whereas you see a huge distribution, which I circled with the yellow line for sevoflurane, even if you have a low body mass index, which I can just dream of 20. But you see there is a huge distribution. And just to keep in mind, 1,000 seconds is 17 minutes. So even if you have a perfect body mass index of 20, there is a huge distribution in terms of return of airway reflexes. And the explanation is pretty simple. If you have a higher solubility of a gas, you have a longer storage of the anesthetic drug in your body, and this is reducing the recovery of the patient. If we convert this table into the table from the first graph, you can see even if you have a body mass index of above 30, 96% of the patients are able to swallow 2 minutes after proper responding to commands. So when people are waking up, proper responding to command, you can be sure that the airway is protected. And look at a body mass index of above 30 in sevoflurane. Less than 20% are able to swallow properly. In Germany, we have a lot of patients with a body mass index of above 30. And for me, as head of department, if I can increase dramatically patient safety just by using the right drug, this is something which is really very, very effectful. And this is, again, the explanation is simple. If you have a higher solubility of the gas, you have a lot of storage and a lot of slow elimination of the drug. And this is why all these kind of things are impaired. But the thing is, those people were proper responding to commands, and still, when they properly responded to command, they were unable to protect their airway. If you look again at the influence of anesthesia time on return of airway reflexes, you see the narrow corridor of desflurane. No matter how long you are applying desflurane, the return of airway reflex is very predictable and very consistent. Whereas even after short-term operations, as you can see, within less than 1 hour or around 1 hour, there is a huge distribution for sevoflurane. Again, the higher solubility is the reason and causes that prolonged or non-predictable elimination. Another thing, as I already mentioned, is cognitive function postoperatively and pulmonary function. And this was a study done by Federico Pilotta in Italy a couple of years ago, and he was looking about the cognitive recovery and the gas exchange patterns after balanced anesthesia in neurosurgical patients. And we all know that we have to keep those patients, when they wake up, stable, because it alters cerebral blood flow if there is any changes. And what he clearly showed is that after sevoflurane in those neurosurgical patients, there was a drop in pH values 15, 30, and 45 minutes after extubation. And this corresponded, as you can see downstairs in the bottom graph, with an increase of CO2. So there was impaired ventilatory function in those patients. And this again is the thing that the upper airway, the pharyngeal system, is very sensitive. I will come back to that later on, neuromuscular blocking drugs as well. So if there is a collapsibility of the upper airway, there is an impaired ventilation, and this caused the increase in CO2, and this caused the drop in pH values of those patients. And if we look at the postoperative recovery, you can see within 19 minutes, all patients, all these neurosurgical patients were fully recovered to an Aldrich score of above 9, compared to 39 minutes in sevoflurane patients. And probably one or another might say, well, is this important? I do think this is important in terms of safety and outcome relevance for the neurosurgical situation. Because if we wake up those kind of patients after craniotomies due to tumor surgery, it is important for the neurosurgeon that they evaluate whether the patient can move all the limbs, he can feel everything. And if you figure out there is something wrong, to go again to do C-scan and to do probably some reoperation. And this might protect the patient from harm in the future. Well, again, when we look about postoperative lung function, the question is there any impact on propofol on those kind of things? And very interestingly, that Martin Soremba from Germany published a very interesting paper when he was looking at postoperative lung function. And what he found out is that compared to desflurane and Tiva, that patients immediately after surgery, after extubation, half an hour after extubation, 2 hours after extubation, and even 24 hours after extubation, they had better saturation values after desflurane anesthesia. So the question is, why should people have better saturation compared to preoperative values in desflurane compared to Tiva? So the question is really, why should propofol inhibit any pulmonary function? This doesn't make sense initially when you think about it. But what Martin Soremba clearly showed, that he did lung functional testings immediately after extubation, half an hour after extubation, 2 hours and 24 hours after extubation. And he showed, as you can see on the bottom here, highly significant difference in the results of those lung functional testings. No matter if he did FVC, forced vital capacity tests, if he did FEV1 or flow testings, yeah, every single test at every time point was highly significant better in desflurane patients compared to Tiva patients. So the question is, why does this occur? And the answer has been given already a couple of years earlier, published in 2005 in Anesthesiology by Eastwood. And he clearly showed that with increased levels of propofol, there was an increased need of the critical pressure to open the airway. So the collapsibility of the upper airway causes the restriction in ventilation. So it's not a pulmonary problem, it's a problem of the pharynx, that those patients have a collapsibility of the upper airway. And this is why all those lung functional testings are worse than with desflurane, because the integrity of the upper airway of the pharyngeal system is going down. This is like here in Europe, you know, when people drink too much alcohol, people are snoring at night because alcohol has the same effect. It causes a collapsibility of the upper airway. So it causes the obstruction. And this is why lung functional testings are going down. And the result of that is that the saturation is going down. So the second point I would like to draw attention is residual neuromuscular block. We do know that relaxants have a negative effect if we have a residual neuromuscular block. And this is due to the fact that the occupancy on our neuromuscular junction between force and occupation of receptors is not a linear relation. It's not a linear relation. It takes us around 70% of occupancy of the receptors until the muscle force is going down. And on the other end, this means only a liberation of around 30% of neuromuscular receptors on the postsynaptic membrane. The liberation of only 30% of those causes the whole clinically and technically measurable recovery from neuromuscular blocking drugs. And this is why it is so important that we get to that point, to the full recovery, that we measure this. Because if we leave patients out with this, we cause trouble. And this has been already shown in 1997 by Professor Wibbe Mogens in Denmark, when he was asking his senior staff members to bring all patients fully recovered to the PACU. And then he was measuring there. So people were forced, experienced anesthetists to do whatever they wanted, but to bring patients fully recovered to the PACU. And what did Wiebe Mogensen find? He clearly found that about 90% of patients receiving pancuronium had residual neuromuscular block. Even experienced anesthetists figured them out to be fully recovered. And what he showed as well is that around 50% of patients receiving vecuronium or atracurium has been declared fully recovered, but they were not. 50% undetected, clinically undetected residual neuromuscular blockade. So experience is good, but experience does not mean any safety for our patients. We have to measure them. And about 20% of those patients who had the residual neuromuscular block showed pulmonary complications later on. So the thing is, we have to observe the full recovery of every single patient. And to strengthen this argument is that a couple of years ago, Benoit de Bain measured the recovery of a single intubating dose of rocuronium, of atracurium, or of vecuronium in normal doses, normal intubation doses. And we all know from the package insert that these drugs should work or should last for about 1 hour. But when you look at those data from France, and 700 patients participated in this investigation, you see at 1 hour, 60% of the patients did not recover to a TOF of 0.9, which is considered the safe endpoint nowadays. 6 out of 10 patients had residual paralysis. So probably you might say, Professor Püringer, give them just a few more minutes. And then we will figure out that even if we wait another 30 minutes, there is no, it's not getting better. There is still about 60% of the patients who have residual paralysis who are not fully recovered. And even if we wait another half an hour to 120 minutes after a single bolus dose of those drugs, still 30% of the patients have residual paralysis. So the thing is, there is a huge individual variation of our patients. We cannot predict anything. Clinical experience does not tell us anything about the response of the individual patient. And again, probably someone might say, well, but you know, there is a difference in terms of metabolism, like atracurium is organ-independent elimination. But when we look at the data, there is no difference between the drugs. It's not the metabolism that causes prolonged elimination. It's the individual sensitivity of the drugs. And this is why we have to check every single patient who receives a relaxant. The second thing from this study was that they were looking at the sensitivity of clinical and tactile tests. And you see the sensitivity is low, it's about 10%. What means sensitivity? Sensitivity means that we have a positive clinical or tactile result when we test the patient. Please lift your arm, press the hand, show the tongue. And we think the patient is doing all of these things, but when we measure this patient exactly, we figure out that it's a negative result. We see the specificity is high, but this doesn't mean anything, because if there is a negative clinical or tactile test, the patient doesn't benefit out of that. So the thing is, the sensitivity is low of clinical tests and of tactile tests. This is why we have to measure with a quantitative monitoring. And this was also the conclusion of this paper by De Bain. TOF monitoring, quantitative TOF monitoring is the only thing that gives us valid data. Why? Again, because not all muscles are the same. We know that the diaphragm is the most resistant muscle in our body. But the pharynx, the pharyngeal muscle, is the sensitivity. This is the Mr. Sensitivity. And this is why this is the last one to recover from neuromuscular blockade. This is the same like with volatile anesthetics or propofol. The pharyngeal system is so sensitive to all of those influences we are adding as anesthetists. But the measuring is on the musculus adductor pollicis. So the function of the pharyngeal muscles at residual neuromuscular block, and this is also done by awake volunteers in Sweden by Lars Eriksson, and he clearly showed that the upper esophageal sphincter tone is dramatically going down when we have a TOF of 0.6, 0.7, 0.8. And those students, they were not anesthetized before. They were even not able to swallow properly when they had a TOF of 0.6, 0.7, or 0.8. So we have to recover our patients to a TOF of 0.9 unless they are safe to protect their airway. And this is the same thing that the collapsibility of the upper airway. In relation to low TOF values, the collapsibility of the upper airway occurs. And this has been published by Matthias Eickermann a couple of years ago. And he clearly showed, even with MRI imaging, that there is a collapse in the pharyngeal structures. And this was equivalent to the reduction in flow rates. Yeah. So residual paralysis, just like residual volatile anesthetics in our body, cause a collapsibility of the upper airway. And the second thing I would like to draw attention is that muscle relaxants do not only work on the neuromuscular junction, they also have an impact on the glomus caroticum. And this has been already shown 100 years ago when Jacques Heimann in Belgium showed when you drop acetylcholine on the glomus of mice that short-term hyperventilation occurs. He couldn't explain it 100 years ago. And it took 50 years more in 1982 that Ezeguer found nicotinergic and muscarinic receptors on the chemoreceptor cells, and they react to neuromuscular blocking drugs. And 10 years later, in 1991, already 30 years ago, Fitzgerald showed that after the administration of tuberculin, after a muscle relaxant to those receptors, there was no receptor output in presence of hypoxemia. So in a hypoxic state and the block of the glomus caroticum, there is an inadequate response for hypoxemia. And we all know that the glomus caroticum is our guard in terms of hypoxemia. And Lars Eriksson again took some volunteers, some medical students at the Karolinska in Stockholm, and he only had 2 groups or 3 groups. He had the control group. He had a group where they titrated them down to a TOF of 0.7 and to a TOF of 0.9, and they exposed them to a hypoxemic gas mixture. So they all had a saturation of 80% on the finger, 80% saturation. And you see at the TOF ratio of 0.7, which is the middle columns here, there was a dramatic, significant reduction in terms of tidal volume and minute volume. So there was an inadequate hypoxic response, but those volunteers were not exposed to any other anesthetics. And they were unable to respond properly to hypoxemic situation. This is why it is so important that we have to recover our patients to a TOF ratio of 0.9, because at that time point, they are able to prevent a hypoxic simulation by increasing the tidal volume and by increasing the minute volume, what is needed to prevent from hypoxemia. And this is why Eriksson just wrote in an editorial also already a couple of years ago that every patient who receives a muscle relaxant should be measured quantitatively with neuromuscular monitoring, because it has little risk and the benefit in terms of outcome is relevant. So quantitative neuromuscular monitoring can be started at any time. There is no calibration necessary. It's easy to apply. You have to take care about the positioning of the arm and the thumb. It has to be free because it's moving, and you can evaluate the onset, and it's very accurate for recovery. And it gives us reliable results. And we should try nowadays, just very, very recent results showing that we should get a TOF of 0.95 for our patients, because then we are sure that there is also no rebound occurring in terms of recovery. So these are the techniques we are using in my department. There is the NMT module or the accelerometrics by the TOF watch. These are the 2 measurements which are easy to apply and which give us the necessary effect of safety in terms of neuromuscular recovery. So to come to the conclusion is anesthesia challenges are changing, and the needs for the future is we have to shift to modern drugs. and we have to optimize our anesthesia techniques. We have to get away from that, what we have done in the past. We have to look which is beneficial for our patients. We will not get a lot of new drugs in the future, but there is some very, very good drugs available. We just have to work with them. Yeah. Well, there are great challenges to maintain the high patient load and to optimize our OR turnover. And desflurane is one of the devices or the gases which really provides faster, more predictable and complete recovery in terms of turnover in the OR, but especially in terms of patient safety. And this is the most important thing for me as head of department, as an anesthetist. Patient safety. I would like to provide the best patient safety for my patients. I would like to treat every patient the way I would like to treat my family. Well, drugs are only tools. Drugs are tools. We have to correct use them. So we have to avoid overdosage. This is why we just need 0.7, 0.9 Mach of anesthesia gases. Yeah, do not overload your patients. Yeah, in the presence of opioids, the Mach is going down. Be careful about the opioid use. I absolutely advocate that we should use opioids. I'm not a fan of opioid-free anesthesia because we anesthetize patients 1, 2, 3 times in their lifetime. So there is no danger in opioid abuse like in the US. We do not give them it. Do not give it on a daily basis. So careful use of opioids. The amount the patient needs gets the patient. We avoid really IV benzodiazepines. These are dirty drugs, even though like midazolam, short-acting drugs, these are dirty drugs in terms of cognitive postoperative function. We have to be clear that if we use short-acting drugs, we do not interfere in this sensitive system too much. And apply to every patient who receives a neuromuscular drug, like relaxants, a quantitative monitoring. For volatile anesthetics, take those ones with lower solubility, because lower solubility corresponds with predictability and reliability. And be aware of the fact that propofol and Tiva can cause postoperative impaired ventilation because of the collapsibility of the upper airway. And this is why we have to keep in mind that we can avoid in situations those kind of things impairing postoperative ventilation. And by that, I would like to thank you for your kind attention. It was a great pleasure being part of this symposium.
Thank you very much, Professor Puringer, for your very detailed presentation about the modern anesthesia. And I get some point of view that talk about how we choose the right anesthesia agent and how to monitor some of the residual paralysis that you're really fear about the safety of the patient. So I think there will be so many questions for you in the last session, because it's a very interesting and detailed presentation. Thank you, Professor Puringer, for your very interesting presentation. So let me move to the next speakers. Okay, the next speaker is Dr. Claire Rose is a consultant of anesthesia and pain specialist. Now she's working in National Health Services in the United Kingdom, and the chair now she's the chair of the Pain Management Committee of WFSA, World Federation Society of Anesthesiologists. She has an interest in a global aspect of pain management with her PhD in this field, and he has led many essential pain management educational workshops across the world. So, Dr. Clay, you have a 30-minute presentation and your topic about the pain management, a global perspective. Okay, Dr. Clay, time is yours, 30 minutes.
Thank you very much. Thank you. I'll just get my slide sharing. I will just confirm, as you can see, that photo is a little bit old. I didn't know you were going to use that. I've gone much grayer since that photo was. And actually, because I'm from the UK, I'm not MD, but I am a medical doctor. We just don't use that that set of letters. So here we go. I hope you can all see this. from the start. You can all see?
Yeah, okay.
Great. Well, I'll start. So thank you very much for the invitation to speak this morning. It's still quite early in the United Kingdom, but it's really good to be here. And I'm going to give a bit of an overview about some aspects of pain management to try to bring things together quite globally. Why is this not moving forward? There we go. As you said, I'm an anaesthetist and pain specialist in the UK. I've also got a PhD in social science and medicine, looking at some of the more global aspects of pain management. And I've got an interest in education and have been involved in the programme Educational Pain Management, which I'll talk a little bit about. So this morning, or this morning for me anyway, maybe this afternoon for many of you, I'm going to talk about very globally why I think we need improved education in pain management, and just to bring together some of the things you will know about, I think, but just to put them in a wider context. We were just heard then about mentioning opioids and the use of opioids across the world. So I'll talk a little bit about that, why I think we need better education in pain management, and then about this program EPM, which I think some of you will be aware of in Indonesia, but I'll just give a bit of an overview of the course and where it's going. So how do we quantify pain? It's really quite difficult on a global scale. When we look at acute pain, so short-term pain that goes away, there are various figures that are put around, but a lot of people still suffer from severe pain after surgery and trauma. Often pain after surgery and trauma is not well treated. A huge number of the world's deaths are due to injuries. And according to a Lancet commission, we should be trying to increase the number of surgical procedures done. So across many areas of the world, there's a huge shortfall in access to surgery. So the number of people who should be getting surgery or could be getting surgery is probably a lot higher than it is. So not only is there a problem now with acute pain, but it will likely get even bigger if we try to meet the mismatch in the amount of surgical surgery that's provided. When we look at chronic pain, again, estimates vary because it's difficult to quantify and to define how significant chronic pain is. But generally, people talk about 20 or 30% prevalence in populations of chronic pain. And finally, the third area we tend to divide pain into in medicine will be pain related to the end of life, so pain in a palliative care context. And there's been a big set of work done by a Lancet commission, and I'll talk a little bit more about this later, a Lancet commission on access to palliative care and pain relief. And they published a few years ago suggesting that over 60 million people are actually in need of palliative care and pain relief. And as with many of these areas, more than around 80% of these people who are in need of palliative care are in low and middle income countries. So I'm just going to talk now on the back of that on opioid distribution. Now, I think we're all aware that opioids are very good treatment for acute pain and pain at the end of life. There is a difference when we think about treating using opioids for chronic non-cancer pain, where there isn't good evidence on a population basis that they are generally helpful. There is evidence of harm. But I'm just going to talk about the use of opioids more globally. So here, again, from the World Health Organization, which ties in with the last slide, they estimate that over 80% of the world's population live without access to treatment for moderate to severe pain. And as I said, here they're talking about access to opioids. And when we look further at that data, we can see that of nearly 300 metric tons of morphine equivalent that's distributed per year, just 0.1 of a metric ton goes to low-income countries. So if we look at the opioid consumption graphs, there's some very good data available because every country has to report their opioid usage to the International Narcotics Control Board. And that data is actually collated. It used to be collated by a group at the University of Wisconsin. They've now moved to Indiana. You can't, when I last looked, it was difficult to get all of the data myself through their website, but they have some very good tools for being able to look at data from each country. This is one of the graphs that they've produced. Now, this is looking at per capita use of opioids. And here we've got a couple of countries and a few regions. So the large blue rectangle on the left is the United States, next to them the United Kingdom, and then barely visible actually are slithers of Africa and Southeast Asia. So each of these, sorry, somebody's got their microphone off, I can hear. That's okay, I'll keep going, it's fine, I was just distracted. So there are, you can see here that not only are Africa and Southeast Asia on this graph very, very small, which shows that they've got very, very low levels of opioid consumption, but actually the United States is extremely high. Arguably, the United Kingdom is high as well. There's a red line across the graph here, which shows the global mean for the amount of opioids used per capita. But there are two issues here, I think. One is an issue of low use, but also the issue of overuse, and they're both present. I'll talk a little bit about it in a minute. This is another graph of data from the same group. It's just in a different format. I was afraid I'm not able to change that. This is just showing every different region from the WHO. And you can see on the left, the Americas are very, very high, again showing, sorry, again, ooh, very, very high. I can't go back. How do I go back? Thank you, sorry. This is, it just shows how high the use is in America and in Europe, and then over on the right-hand side of the graph with Africa and Southeast Asia and other regions, very, very low. So I will talk a little bit about low levels of use, although I don't want to tell you things that you're over familiar with, but I'm just going to spend a little bit of time talking about overuse, because I think it's important to understand both sides of the issues, to understand where the problems lie and how things can affect all of us. I think it's important to understand from a global perspective. So there's some very alarming figures that have come out of North America. This, I think, is from the United States. And there's been a lot of media coverage of problems in the United States of overuse of opioids. You can see here, this is an infographic from the United States saying that over 130 people are dying a day from opioid-related drug overdoses. That 11.4 million people have misused prescription opioids. One word of warning on this slide, they have also included data from illegal use, so from drugs like heroin. But nonetheless, this does point to a problem of problematic overprescribing or overuse of prescription medication. But I think it's important to understand this in a little bit more detail, because it is relevant, I think, to everyone globally, because it's easy to get, if you don't understand it properly, then I think it could be, people can sort of move to one extreme or the other very quickly. It's quite contentious, everything that's gone on with regards to overuse. But essentially, and things are very debated, essentially, I think there's three reasons why it's happened. First of all, there's been an overzealous use in the treatment of chronic non-cancer pain. And as I said at the beginning, we now know, although the evidence has come about more recently, that there isn't good evidence at the moment for using opioids for chronic non-cancer pain, although a few people may benefit. In general, population-based studies, there isn't good evidence for benefit, but there is evidence of harm. It's not the same, of course, for acute pain or pain at the end of life, but for chronic non-cancer pain, we don't have good evidence. Now, there is an additional problem in the United States, certainly compared to where I work in the UK, and that there are multiple prescribers, but this will happen obviously in many countries in the world. So it's relatively easy for patients to be able to get multiple opioid prescriptions if they want to. Where I work in the UK, that's really quite difficult to do, because everyone really is assigned to one general practitioner or family doctor. And it's quite difficult to get prescriptions from other people. And the other thing that happened in the United States was that there was direct marketing to patients. And this has become a big litigious problem now. And a lot of companies are being taken to court over how they marketed to patients. So some of these things are going to be relevant to us. Other things may or may not be relevant depending on the country you're working in. But certainly, I think the overzealous prescribing for the treatment of chronic non-cancer pain, we need to be aware of. And there's been a lot of change in the national level guidance. Opioids Aware is a freely accessible website in the UK, but many countries have got new guidance now on how best to use opioids. So I'll leave that for a bit and just also highlight some of the reasons for low levels of use, which I'm sure you're all very familiar with. But a lot of the problems are around education. So people are often quite afraid of using opioids in some countries. People are afraid for lots of reasons, but partly because they are not very used to using the medications. And people can be concerned, partly because of the slides I've just been showing you, about risks of addiction and of misuse, even for using the medications in a palliative care setting, so at the end of life, or for acute pain. And we know that using opioids in acute pain and at the end of life is a far less risky area. We're far less likely to get problems of addiction and misuse. I'm not saying it never happens, but we're far less likely to. But people are very afraid of using opioids, and there's this thing, the phrase has been coined, opiophobia. And this sort of fear of using opioids, both by doctors and patients and even managers, has led to overly stringent legislation, often led by the fact that people are worried about the use of illegal drugs. A lot of countries have policy that's very much weighted towards trying to stop people from misusing drugs. And this has led in some countries to very bureaucratic situations, and it can be very, very difficult to overcome the bureaucracy. People can be afraid of what might happen if they misprescribe medications, and it becomes very, very difficult to practically use opioids in an appropriate setting, so for acute pain and pain at the end of life. And there's also sometimes issues around availability. So there's data to show that opioids are more expensive, relatively speaking, in lower income countries. And there can also be problems around access from the pharmaceutical industry. So sometimes, because very, very cheap formulations like oral morphine are so cheap to be made available, there isn't a good profit to be made. And so sometimes it's the more expensive formulations like fentanyl patches that might be available, but because they're in the pharmacies and the lower cost medications aren't stocked, many people obviously can't afford the fentanyl patches, and therefore you still have a problem of low levels of access. And a lot of this is put together in a very important paper from 2007, talking about the WHO model that brings together a lot of these issues around poor access to opioids. So I'm just going to now highlight some of the work that's been done to some of the papers that you may want to have a little look at that highlight some of these problems and bring them together. I think, as you can see, I hope from what I've shown you before, that there is a problem of overuse and a problem of underuse, but we're talking about the treatment of different types of pain here. That said, that can be quite difficult for everybody to understand and to take on board, and that requires quite a lot of knowledge to be able to use opioids appropriately. So really that highlights to me the need for education. There is some work out there showing us other people talking about the need for education. This is a little bit old now, this 2007 survey, but it's an important survey from IASP, the International Association for the Study of Pain. And it's a report looking at education in countries and showing that there is definitely a need for improved education and training. It says here developing countries, but as we all know, I think there's a need in every country. This is an important piece of work which you might want to look at if you're interested in this area. This is called the Global Opioid Policy Initiative. And this is a set of papers that shows levels of availability of opioids for many, many regions across the world. And it's got some very good comparative data. And a lot of the future work is been based on some data and some work from this project. So this is definitely worth a look. There's also, from an advocacy point of view, this is a very useful document. It's the second iteration, just recently published. This is the Global Atlas of Palliative Care, and it draws together some of the data that I've already shown you in this talk. It's a big document, but freely available, and it shows the levels of palliative care that are available throughout the world, in all countries. And it also talks about what palliative care would be needed if we were able to give a perfect service. So it both shows where we're at and what we would need. But it is important to remember that this is very much based on palliative care. And a lot of the big work that's been done is on palliative care. That the last project I just showed you as well is looking at opioid access in palliative care. There is relatively less work done on access to opioids, on the treatment of pain at a broader level. A lot of this work comes from palliative care and therefore misses out some of the work that would be needed on chronic non-cancer pain or acute pain. Anyway, this is a very good document if you're interested, and very good for advocacy, because it explains a lot of the need. Similarly, this piece of work from the Lancet that I mentioned at the beginning, this is the Lancet Commission on Global Access to Palliative Care and Pain Relief, released several years ago. And it talks again about the inequity in access to palliative care and pain relief. They have a slightly broader remit, but there's some very powerful slides like this one, which shows a map of the world with the land area distorted to show the amount of opioid that is available in a country compared to the amount that's needed. And you can see here that countries of North America and Australia are grossly swollen, whereas Africa, South America and Asia are barely visible. I think it's a bit of a shame, actually, that they didn't invert this graphic so that the countries that don't have availability are made larger, because I think we often see America and Australia as being larger, and I think it would be interesting to see that graphic round the other way. Nonetheless, it's very interesting and a very useful way of seeing what's happening in the world, showing you that I think there's a problem in America as well as problems of underuse. And I just want to draw your attention to one element of this paper, because although I've said there's a clear difference between how we treat pain at the end of life and how we treat pain for chronic non-cancer pain, I just want to show you that actually those the margins between those two areas are actually quite blurred sometimes, and it can be difficult sometimes to see the differences. That also is why I think we need good education and good understanding of this area. So when we have a look at this Lancet Commission report, they talk about this concept called serious health-related suffering. And they are coming at it from a palliative care point of view. But as with some people in palliative care, in some areas, there is an increasing remit in the world of palliative care. So they say that the remit of the report was to talk about all health conditions associated with end of life. They said that they decided to look at chronic, acute, life-threatening or life-limiting health conditions, diseases, and injuries. They said that they explicitly reject any time or prognostic limitation on access. But they also said in the report that they decided not to focus on acute or chronic health conditions that are not life-threatening or life-limiting, including chronic non-malignant pain. Now, what I think this does is demonstrate some of the, as I said, the blurring of the edges of these two areas, because I think there is a really an overlap between the second statement there, chronic or acute, life-threatening and life-limiting conditions, and a lot of patients with chronic pain, certainly who I see. I think there can be an overlap between those two. And there can be a tendency in some parts of the palliative care field to be increasing this remit of palliative care, as I said, and it is blurry around the edges. And it's something that I think we need to be aware of, and aware of the differences in the different ways that we use morphine for different types of conditions. So it's difficult, it's complicated, and therefore I think it's important to have good education if we possibly can. So moving on to the second part of my talk, I'm going to talk a little bit about essential pain management, this educational program that I've been involved with that covers many of these areas I've just described. So what is EPM? It's an off-the-shelf package, a bit like other programs you may have been involved with, like PTC or SAFE. In the UK, we have ALS. It's for all healthcare workers, and the idea is to improve knowledge about pain. And it's about all areas of pain: acute pain, chronic pain, pain at the end of life, or cancer pain. And it's about providing a simple framework for treating pain, and also to look at barriers which will be different in different areas and how these barriers can be addressed. We usually run it as a one-day workshop, although there's some newer formats coming out now since COVID. But we usually run it as a one-day workshop. There are lectures in the morning with lots of interactive discussion, some case-based discussions, and then some much more interactive sessions, both around the cases and around barriers. We also run a half-day instructors workshop alongside it so that we can get local handover very quickly and sustainability of the programme. We use this concept, which is the RAT, and we use it as an acronym to treat pain. So we talk about recognising, assessing and treating pain. But we use the RAT because untreated pain, like a RAT, is unpleasant. It's usually relatively easily treated, but you often can't see it. And it's important to use all those elements together. This is just a selection of some of the slides. I won't go through all of them, obviously, but just to show you the sort of things that we teach, and how we conceptualize pain. So we talk about why we should treat the pain, and that it's important both for the patient, but also for wider society. We talk about how we assess pain, so looking at broader measures, but also some of the analog scales and numerical scales that we might use in hospital. And we talk about why it's important to classify pain. And I think I've explained to you earlier on why it's so important to classify pain, whether it be acute or chronic, whether it be cancer or non-cancer. And really there we're talking about pain at the end of life or chronic pain. And whether pain is nociceptive, so normal pain, or neuropathic. And the reason that matters is because the treatment depends on the type of pain. As I said, that's particularly pertinent at the moment with the use of opioids. We talk about physiology, and this is just to show you the detail that we go into. But it also want to show you here that you can actually change the way you teach the lectures. So some people may want more physiology than this, some of the medics, some other people might want less physiology and be a bit overwhelmed by some of these slides. But we try to break it down as simply as possible, and it's really quite a malleable course, so you can change elements of it that you teach, and you can make it more complicated for some students, and you can simplify it for others if necessary. This is a picture that we often show, and it often gets people thinking a little bit. So we try to make things, as I said, very interactive and get people to think quite a bit about the emotional aspects of pain, and why somebody might be suffering more than somebody else for the same type of pain that they are experiencing. And we talk about pain medications. So we particularly, as I said, make sure that we talk about morphine, which is very effective for cancer pain, certainly cancer pain at the end of life, and acute pain. But in general, that strong opioids should not be used for chronic non-cancer pain. And we talk about pain management barriers. We talk about why pain may be difficult to overcome locally. And there'll be all sorts of different things that will happen in different areas, but we very much make sure that that section is from the participants, and that's about facilitating the participants to understand how they might be able to overcome their own local barriers. As I said, we have some interactive case discussions. We have a variety of cases. This one, for example, is an acute pain. So somebody who's had some traumatic injury with a machine. We will have cancer cases. So this is a lady with metastatic cancer. And this is a patient who has got is it neuropathic pain? Yeah, he's got neuropathic chronic pain. So we cover a big range of the different sorts of pain that people might come into contact with. So the workshops have been very successful. They were originally written by Roger Gook and Wayne Morris with the Australian New Zealand College of Anaesthetists. They're a pain specialist and an anaesthetist. First run in Papua New Guinea in 2010, but now it's been run in over 60 countries, many language translations. There's a WFSA, a World Federation of Society of Anesthesiologists steering committee, and there's just been launched actually an online version, which some of you may want to have a look at. We also try to evaluate the course, which is difficult in a way. We do multiple choice questions for participants at the beginning and the end. We ask for feedback from participants. We're also trying to look at some longer term work on what the impact is of essential pain management. And we've looked at multiple choice question scores over periods of time. And we've also got data from interview studies with clinicians involved in the work. We've looked at a thing called commitment to change, which is asking people about how their practice has changed, how they'd like their practice to change. And we sometimes link in our work with clinical audit and with looking at service provision locally to see if we can look at some of the on-the-ground changes that can happen. But it's difficult to get some hard data to draw all this together, but we do have some coming. So in summary then, there is, I think, a need to improve education and pain management at a global level, particularly with everything that we're hearing about opioids, both low levels of use and high levels of use. Essential pain management is a tried and tested model with increasing popularity in both low and high income regions. We run it in the UK very regularly. And the comprehensive evaluation, though, and sustainability of this programme remains a challenge. Thank you very much.
Thank you, Claire, for your very informative presentation. And I'm interested in, about how big difference of in the world about the pain management. You can see that there is no overuse or there is underuse of the opioid in this part of the world. So it's very nice to discuss later in the discussion session. And of course, your information about the essential pain management. It will be very nice course to all the participants to get maybe in online too, because it's available now. Okay, thanks Claire for your presentation, and we can move to the next speaker, Dr. Surapong. So Dr. Surapong is Associate Professor in Faculty of Medicine, Chiang Mai University. He is a hyperspecialist skill and expertise in cardiopulmonary bypass, and he will be talk about the update in peri-operative hemodynamic monitoring. Dr. Surapong, you have 30 minutes for your presentation today. Time is yours, Dr.
Thank you very much. May I share my slide, please?
Yes. Okay. Claire, okay.
Okay. Thank you very much. Thank you very much for inviting me. And ladies and gentlemen, first of all, I'd like to express my sincere appreciation for the fantastic organization and congratulations for the Hasanuddin University for the anniversary. And my talk will be focused on the updates in the perioperative hemodynamic monitoring. And I'd like to welcome all of you to Thailand next year as well for the Asian Society of Cardiothoracic Anesthesia in 2022 by the end of next year in Chiang Mai, the north of Thailand. My talk will focus on what is the difference between the hemodynamics and how we can optimize the hemodynamics that we see every day in daily practice. Normally, we have to understand the physiology of the electrical that transform and transmit change to the mechanical, and what's new and what is the update. Right now, the trend is move from the invasive to the non-invasive, and the simple parameter, for example, like the ECG and the pulse oximeter, now is useful better more than only heart rate or the oxygen saturation, because the delay time from the ECG to the pulse oximeter is called the pulse wave transit time. The pulse wave transit time is related with the stroke volume, because if the pulse wave transit time is very fast or it's very short, it means that stroke volume is increased. Or if the pulse wave transit time is slower, it means that the stroke volume is reduced. Because the physiology is the ECG to the uprising of aortic root is related to the contractility. And from the aortic root to the uprising of the radial artery is related to the blood pressure. And from the radial artery to the pulse oximeter is related to the seismic vascular resistance. And if it's summary all the things together related to the pulse wave transit time is stroke volume. And before we analyze the data, right now, several years ago, we used the heart rate to guide our anesthesia. We use our blood pressure to guide anesthesia. It's still useful, but we have to think about another factor as well, because when we have the hypotension, when the patients have hypotension, it may be from our anesthesia too much, or sometimes our hypovolemic shock, we have the blood loss, something like that. And we have to monitor another thing, for example, lactic acidosis or the urine output as well. For example, if we would like to have a look at the blood pressure to guide, we have to think that the factor that involved to our blood pressure change, we have to optimize our anesthesia first. We have to make sure that our anesthesia is not too much, not too low, in the optimum level. Like in the first lecture, that we have to monitor for the residual anesthesia to be not too much and to be not too low. After we optimize anesthesia, then we have a look another physiology or the pathology change, like the vasoconstriction or vasodilatation changes. And when we have the blood loss is the most common factor that happens in everyday practice. When we have the blood loss and we replace with the crystalloid or the colloid, it means that we lost in the stroke volume, right? When we lost a stroke volume, the body tries to compensate it by increase the seismic vascular, by increase heart rate to compensate with the normal cardiac output to maintain blood pressure normal. However, when the cardiac output is starting to fall down, the body tries to compensate it by increase vascular resistance, and this one is from the vascular tone and the blood viscosity. Every time when we see the blood pressure fall down lower than 65, it means that the body cannot compensate. This one lower and SVR cannot compensate. That's why this is called the decompensated shock, and this is a compensated shock. However, another physiology that is very popular from this era is the Vesocritic syndrome or the septic shock, because right now we have the coronavirus, we have the ARDS with sepsis, right? When we have sepsis or the Vesocritic syndrome, it means that the vascular tone is lost. Seismic vascular resistance is fall down for a long time. and the body tries to compensate it by increase the cardiac output to prevent blood pressure to be fall down. But if we cannot solve the problem, cannot optimize SVR until the cardiac output is maximum, that's why blood pressure fall down, because the Vesocritic syndrome, the vascular is dilated and the vascular tone is not so good. And how we can optimize the volume standard, right? Before we would like to see the stroke volume, right? One part of the cardiac output is stroke volume. How can we analyze the stroke volume? Can come from the Swan-Ganz technology, can come from the echocardiography. All right now, the update data is moving for the non-invasive one or the less invasive one, like from the ultrapulse contour cardiac output from pulse, and the big of the pulse or the area under the curve of the pulse is related to the stroke volume. And can we use this one to guide the volume status, because previously we know that the volume status we move from the static parameter to the dynamic one. The central venous pressure we move to the dynamic one, which is more than one parameter. Stroke volume variation, it means variation of the stroke volume, variation of the pulse oximeter, or the plethysmography index, or the PPV is the pulse pressure variation, is the dynamic one. If we would like to use the dynamic parameter, we have to understand that it's from the heart-lung interaction. That's why before we analyze this data, we have to make sure that the heart-lung interaction is big enough to generate the variation. If we don't want to use the arterial line, we can use the PVI from the pulse oximeter as well, but it's far away from the heart. That's why the variation is more than in the PPV or SPV. After we make sure that the SPV, PPV is a heart-lung interaction, we have to make sure that our data is reliable before we use this one to guide. It should be analyzed during control ventilation. So the volume less are more than 8 and closed chest and no cardiac arrhythmia. However, during COVID-19, how can we predict fluid responsiveness before intubation, right? Because before intubation, we cannot do the control ventilation, right? So net breathing without the arterial line, but we have only pulse oximeter, right? Can we use only pulse oximeter to guide our fluid responsiveness in case of the coronavirus before intubation, right? Can we use stroke volume variation? Cannot, right? Because we don't have stroke volume. We don't have the arterial line, right? But we have only the PVI, plethysmography index from the pulse oximeter. However, the PVI is not so good for the net breathing, because the patient have to breathe big enough to generate heart-lung interaction. But in the coronavirus, the patient have dyspnea, cannot generate big theta volume. That's why PVI is not so good to predict fluid responses in spontaneous breathing before intubation. However, from the pulse oximeter, we have the perfusion index or the PI. Perfusion index is a very good one and very non-invasive, easy one. If we do the passive leg raising test, or if we do the fluid challenge test, if there's a change in the perfusion index, if the PI is improved after passive leg raising test, it means that this is fluid responsiveness. But if it's not improved, fluid resuscitation is contraindicated. Another option is before intubation. We can use another non-invasive one, for example, the volume clamp, non-invasive cardiac output, or the bioreactance, or the pulse wave transit time from the ECG or pulse oximeter to guide before and after leg elevation as well. However, after we do the intubation, we mean that we can do the control ventilation, right? Control ventilation and we inserted arterial line. It means that we can use a stroke volume variation. We can use a pulse pressure variation to guide, right? And what we want is, we want to do that after intubation, after induction, the blood pressure should be normalized. But what is really happened is after induction of anesthesia, the vasodilate happens and the blood pressure fall down. How can we know that this patient will have blood pressure fall down, this patient will not fall down, right? How can we know that? Because the first group is a normal intravascular volume. Another group is the compensated intravascular volume. It means in the first group, SVV is 8. The second group, SVV is 18. After 8, vasodilate moves to 17 or 14. It's still compensated. But after 18, it's moved to 28. It means the body cannot compensate anymore because the body in the beginning is in the borderline after vasodilatation from the deep anesthesia or too much opioid or some relaxation like the patient sleep deeply. This will be generate the vasodilate and the patient generate the blood pressure fall down in this situation. In the beginning, if we see the number like this, we have to do the fluid length test to improve the patient to back to this zone. But if in the beginning the patient is this zone, we don't have to give the fluid before to prevent that. However, for the anesthetic management, how many choices that we have to prevent and treatment hypotension after induction of anesthesia? Actually, we have 3 options. The first option is we can maintain the seismic vascular resistance. How to maintain seismic vascular resistance is to maintain with the vasoconstrictor or use the sympathetic stimuli. For example, the surgical stimulation, you can let the surgeon do the surgery or do some starting the forward catheter or echocardiography or something that's painful. Or do the choice anesthesia. You can adjust the choice of anesthesia not to reduce the SVR. Another option is we can use the fluid resuscitation. We just give the fluid. Or the third option is do the titrations of anesthesia, and we just let the body compensated. But if we use the technique that we give fluid, the fluid that we give to the patient is the fluid that stays in the plasma, for example, like a glass of blood like this. With the glass of blood, after vasodilatation from our anesthesia, you can see that the glass is bigger. However, the fluid status is the same amount of the fluid in the vascular, right? But after vasodilatation, if we see the patient at this situation, it means that this patient is fluid responsiveness. The numbers show that this is fluid responsiveness. If we design to give the fluid in this situation, the result is stroke volume will increase more than 10% because the fluid responsiveness means that the stroke volume will increase more than 10% after 200 or 250 amount of the fluid. But my question is, do we have to give fluid or is it necessary to give fluid? Because this is physiology is from the vasodilatation. Why not? Another option is we can do the vasoconstriction. It means that not every time of the fluid responsiveness that we need to give fluid because there are 2 options. First option is give fluid, but if the vascular status is not so good, just optimize the vascular tone by vasoconstriction to go back to this one. And every time we see this number, that this is fluid non-responsiveness. Before that, we have to have a look that, oh, tidal is more than 8 or not, it's controlled or not, and closed chest or not. But if we see a high number, this is from physiologic peak or not, because too high peak, we increase this parameter. And cardiac arrhythmia will increase the number and represent look like the fluid responsiveness, right? This picture show you that how to treat the fluid responsiveness. It means 2 options. Give fluid. Another is optimize the vascular tone if the vascular tone is not normal. That's why the update data is the new number is EA-DI. EA-DI is the dynamic elastance of the arterial. The arterial elasticity of the artery. It means that the major vascular tone is like this one. After the heart pumping and generate the fluctuation of the pulse transit. And you see that in the beginning, the PPV is more than SVV. Pulse pressure variation is more than stroke volume variation and represent the EADI more than 1. The meaning of EADI more than 1 means that if we give fluid to the patient, because in the beginning the blood pressure fall down, right? When the blood pressure fall down, if we have a look at the PPV only or the SVV only, in this number is related to fluid responsiveness. The meaning of the fluid responsiveness means if we give fluid to the patient or if we give preload to the patient, the stroke volume increase more than 10%. However, stroke volume increase more than 10%, is it improves blood pressure or not? We don't know, right? But if we use the EADI is relationship between PPV and SVV. If the PPV is increased more than PPV, number is more than this, EADI is more than 1. EADI more than 1 is mean after we give the fluid to the patient, it will relate with the blood pressure to going up because the fluid that stay in the plasma or stay in the vascular tone will generate and transmit to create the vascular tone to increase the blood pressure. Okay, I show you this one after we give the fluid to the patient. This one, after I give fluid to the patient, you can see that in the beginning it's 1.5, right? But just fall down. But this one is more than 1. It means our give fluid, the fluid will improve the blood pressure. The fluid will improve stroke volume and then improve the blood pressure because the EADI is more than 1. But now the PPV is less than 10, right? This is fluid non-responsiveness, right? And the EADI is less than 1. It means that in this situation, it's okay and we don't have to give fluid anymore because less than 1, the fluid will not increase blood pressure anymore. And now blood pressure come back to normal. Another situation is when we see the EADI is a low EADI, what does it mean? For example, in the beginning, SVB is 16. This one is means fluid responsiveness, right? Preload responsiveness. The meaning of this one is lower than 1. Stroke volume variation increase more than PPV. The meaning is when the blood pressure fall down, the giving of the fluid will improve only stroke volume, but not improve the blood pressure. Because in the beginning, this case is a Vesocritic. The vascular tone is not so good. If we give more fluid, it increase only stroke volume, but not improve the blood pressure. If we see EADI less than 1 and blood pressure fall down, what we have to do is we optimize the vascular tone by giving the vasopressor, right? Sorry. And this one is the paper that show that they use the EADI to guide. When we use the EADI to guide anesthesia or to guide the fluid resuscitation with the use of the norepinephrine, this is a vascular tone or vascular vasopressor. The incident that the decrease in the duration of the norepinephrine in vasocritic syndrome is better when we use the EADI to guide, and it can reduce the length of stay in the ICU and the length of stay in the hospital as well. In case that we're not sure to give fluid or not to give fluid, why not we just do the leg elevation? Because the leg elevation still preserved. No matter we use a propofol or sevoflurane or we use desflurane, the frank styling mechanism still preserved during the operation all the time. But now the trend is moved from the open chest to closed chest, right? And to manipulate something with the heart-lung interaction. Some situations we cannot do the heart-lung with interaction very well. We cannot do control ventilation, or the tidal volume is less than 6. For example, in the coronavirus, we have to do the lung positive strategy, reduce the tidal volume to be lower than 8 sometimes only 6 or sometimes 5 to 6, right? In this situation, how can we adjust our parameter? For example, if we have the low tidal volume, how can we use the SVV? Because the guideline is we use the macro circulation optimization first by optimize the fluid responsiveness from the dynamic parameter like power pressure, stroke volume, pleasure index, and then optimize the contractility. This is the first micro circulation, then macro, and then micro. The micro is from the lactate or the mixed venous oxygen saturation or the near infrared. Nutrient is used near infrared a lot. If there's something happen with the micro circulation, we just optimize the contractility, cardiac output contractility, optimize the hemoglobin because this one is the oxygen delivery, and optimize the oxygenation and reduce the oxygen consumption, right? And I would like to show you this one is the near infrared. It means representative of the micro circulation. Normally it should be more than 50, and we just keep it about 20% of the baseline, right? How can we analyze the SVV-PPV in case of the low tidal volume? In this one, in the beginning, 17. Can we believe in 17? If 17 is okay for the coronavirus, because the coronavirus patients, they cannot generate the big tidal volume, right? In this one, is it reliable? Yes, it's reliable because only low tidal volume. For example, 35, this is fluid responsiveness for sure, preload responsiveness for sure because the tidal volume is very low, but still can generate heart-lung interaction, can generate variations a lot. This situation is fluid responsiveness for sure. And the micro circulation fall down, the body tries to compensate it by the vasoconstriction to maintain normal blood pressure. But now blood pressure cannot compensate anymore because the blood pressure is lower than 65. These patients cannot compensate. What we have to do in this one? This is fluid responsiveness. If we give fluid to the patient, right? If we see SVB and PPV, if PPV is above SVB, this is preload responsiveness and blood pressure will increase. What we see, low tidal volume and high stroke volume variation. This is really fluid responsiveness is very likely, and we consider administration of the fluid if need or if short. Now we just give fluid to the patient. If we give preload to the patient, what we expected happen. This one will increase, stroke volume variation increase, blood pressure will increase, the micro circulation will improve. This micro circulation will improve, right? But however, this one will not back to normal because the micro circulation is part of the hemoglobin. We have the blood loss, but we just keep fluid, just keep the crystalline without hemoglobin. This one will increase only a little bit, but not reach the goal, right? You can see that this micro circulation increase, but not reach the goal. This is increase, but it's back to normal, but the micro circulation not reach the goal. What we have to do right now, after this. Now, you can see that low tidal volume, but our SVB is lower, right? When we see low SVB, what does it mean? No variation, right? No variation, but low tidal volume. It may be from low tidal volume that cannot generate stroke volume variation, right? So we cannot believe in the low tidal volume for the low stroke volume variation because we cannot say low or non-responsiveness for fluid responsiveness. If low SVB is not changed after minute fluid challenge test, or we have to do the tidal volume change to make sure that this data is reliable. After we make sure that this one is reliable, we just give fluid or not to give fluid. Because in coronavirus, to give fluid responsiveness after intubation, we have to have a look at the low PPV. Just test with minute fluid challenge test and test with the tidal volume change. In case that we're not sure to give or not to give, we just try to give stroke volume and have a look at the change of stroke volume. If the stroke volume increase more than 10%, this is fluid responsiveness. For example, this one. This is fluid responsiveness. But this includes less than 10% fluid non-responsiveness or preload non-responsiveness. But now the surgery went well. The patient moved to the ICU. In the ICU, after staying in the ICU for 6 hours, the patient, the physiology changed, and we need to do the prone position. And the prone position, the patients have their blood pressure fall down. This is shock, right? The lactate increased more than 2. This is mean shock, cannot compensate anymore. How can we evaluate fluid responsiveness in this situation? Because this is prone position, right? Normally, if the patients stay in the supine position, we can evaluate with the ultrasound guide, right? We can do the IVC, collapsibility index, right? And we can do the pulse pressure variation with the heart-lung interaction. But now we cannot use the pulse pressure variation because the chest wall is compressed with the prone position. The heart-lung interaction is not enough. And we cannot use the ultrasound guide at the abdomen because the patient is prone. We cannot approach to the abdominal area. And we cannot do the leg elevation, passive leg raising test, because the position is not appropriate for the passive leg raising test. So what we can do? We can do another technique. We just do the prone up and prone down. By the up 13 degrees and down 13 degrees, and have a look at the cardiac output change. More than 8% is related to the fluid responsiveness for the ventilator test. Or we can do the lung recruitment test. Lung recruitment test after we do the CPAP, it's about 30 centimeters water for 30 seconds. If the stroke volume is fall down, about 30% is related to the fluid responsiveness. To summary of my talk is to use the macro circulation optimize and then the micro circulation optimization. No matter what kind of parameter that we use, we can adapt this one. For example, in the beginning, if we calculate our oxygen delivery is lower like this, because lower than 40 is related to acute kidney injury, right? But now in the beginning, hemoglobin is very low, oxygen saturation is very low, PO2 is so low, contractility is not so good. What we should improve? For example, if I improve the lung function to 100% oxygen saturation, improve to this one. And then we can improve the contractility by changing this one. And then we can improve the oxygenation and improve the hemoglobin. I like to show this slide to you because it means that the hemodynamic optimization is not to improve the blood pressure. We have to think about the oxygen delivery. We have to think about the contractility, vascular tone, and how about all the things together. The style of the treatment is mix all the things together. And I'd like to welcome all of you to Chiang Mai next year. Thank you for your attention. Thank you very much. Telemedicine.
Thank you, Dr. Surapong, for your very detailed presentation about our hemodynamic monitoring. I think that our basic physiology understanding need to be deep or explore the parameter that you talk in this presentation. Yeah. And I think there are some consideration that intravascular volume maybe affect the hemodynamic, yeah, but there is some changing in like the induction or other problem in the patient. So maybe we can finish the presentation and we can move to the, thank you, Dr. Surapong, for your presentation. We can move to the discussion. We have, we have 30 minutes, yeah, 30 minutes, I think, for the discussion. And I try to looking for the chatting chat box to looking for some question. I saw a question from, let me see, for Professor Furinger. This is the first question from Dr. Sabram about what do you think about opioid-free anesthesia? Will it replace opioid-based anesthesia in line of safety aspect?
Okay, Professor Puringer, can you have a comment?
Yeah. Well, I'm not a fan of opioid-free anesthesia at all. When we look what people do when they do opioid-free anesthesia, they do a huge mixture of magnesium, of local anesthetics, of whatever it is. So it's a mixture of everything, just to avoid something which, in an adequate dose and at a certain period of time, from my point of view, does not harm the patient at all. So for me, all the thing, is coming up from the US now, and especially in Belgium, there is some guys doing this to an extent where opioid-free anesthesia. Again, as I already mentioned in my presentation, as long as we give it for anesthesia or for intensive care or for a certain period of time, I am not afraid of any long-term effects of that. And I do think that a good anesthesia with adequate dose of opioids does not harm the patient. What I do in general is every patient, before I start pre-oxygenation, before induction of anesthesia, I give them like 2, 3, or 4 mix per kilogram of fentanyl. I call it the so-called welcome schnapps. Yeah. So it's like, and the thing is, then I start pre-oxygenation and I ask the patient, do you feel dizzy? You will get dizzy because you get that kind of schnapps alcohol. Yeah. So when a patient, like an elderly, stops breathing, I do know that this patient is very sensitive to the opioid. Yeah. But as I do pre-oxygenation, I just, backmask the patient. The normal patient usually tells me, I get a little bit dizzy, like having a little drink. Yeah. And some of them will tell me, this is the one who is having the right reaction to it. And some people tell me, I don't feel anything of that. And that means these people are probably used to alcohol or whatever. Yeah. So I know that they need probably a little bit more. So within that administration of the welcome schnapps, I'd figure out whether a patient is sensitive, normal, or needs a little bit more. So I can already figure out the sensitivity. And this is, again, in the next question, someone is asking about how to figure out the right dose. Yeah, this is how we figure out the right dose. So I'm absolutely contra opioid-based, opioid-free anesthesia. I'm absolutely fond of clear thing. What I want as a patient, I want to get fentanyl or sufentanil as an analgesic. I want to be induced by propofol. I want desflurane and an air mixture of 50%, no nitros, and I want rocuronium as my relaxant. And these are the only things, the 4 things I want for my anesthesia, nothing else.
Yeah. Okay, I also agree about the opioid-free anesthesia because it's depend on the appropriate dose, yeah, Professor Puringer, yeah.
Yeah.
It's very nice tips from you, yeah, because we can look in the response of the opioid before we get an induction per patient. Yeah.
That's it.
Yeah. Tips, yeah.
We figure out the sensitive ones. And if someone already stops breathing after like 100 mix of fentanyl, I do know he's very sensitive or she. And then I do not have to add something during anesthesia if it's a short-term operation. And this is what I want to figure out. And again, it's always the poison is always the dose. Yeah. And that's the thing. The best thing, if I overdose, like with propofol, if I give 3 milligrams per kilogram, everyone will get hypotension. But this is the point. If I administer adequate dose, all is fine. And this is what we have to do. We figure out. Yeah.
Yeah. Okay, I think the issue of opioid-free anesthesia is come from, like the United States with the overuse of opioid. Dr. Claire, do you have any comment?
I think it's very interesting what you're saying. I think there is a real danger that because we're hearing about these problems in America that we go too far the other way. And I completely agree with what you've been saying, that there is a time and a place for opioids. And in all over the world, we're using them too much, too little, and about right. And all those things are happening at the same time in in every country, and I think it's a bit messy, and the opioid problem is messy and difficult, but we shouldn't shy away from that. We should accept that using opioids, I think, is a really important part of our practice, and if we don't, we're going to get a whole load of other problems, because people are going to start using ketamine, which in my country is a drug of misuse. So there's no perfect answer, and I think a lot of the problems of misuse I won't go into it now, but are not about the specific drug that's being misused. It's a much more complex social problem. So I think, I completely agree. I think it would be a real shame to say we should stop using opioids, because they're a really important tool for acute pain and pain at the end of life.
Yeah, thank you, Claire. Yeah, because I just upgraded the issue of the opioid-free anesthesia come from the country with the opioid overuses, then come to the country with the low use of the opioid. It will be very terrible anesthesia, I think.
Yeah, and just one tiny point we want to move on, but there are reports coming out of America where people are not finding it much harder to get opioids for an end-of-life care, for example. And that's a real shame. We don't want to go that way either.
Okay, thank you. Yeah,
I absolutely agree. Yeah, I mean, this is very important, because for palliative situations, we need to offer this for the patient to really to reduce the symptoms and the pain in the end of life situation. And especially this is when we reduce opioid administration there, this will be not the way to do it. And therefore, I mean, it's always, as you mentioned, that the pendulum, if in one part of the world they overdose or misuse things like that, that doesn't mean that the whole rest is doing it the same way. And this is why we really have to consider our work, how often and how intense we use it, and then make the decisions.
Okay, thank you, Professor, for this clearly. Okay, I think we have another question to Prof. Springer again. Is there any difference in incidence or duration of residual paralysis between intermittent bolus and continuous administration of muscle relaxant?
Yes, there is. Because of the inter-individual sensitivity towards muscle relaxants, when you give it continuously via infusion, you can do this, but then you have to monitor and you have to adjust the dose to like 5 or 10% single twitch response. So you cannot provide deep neuromuscular block, because once you lose the response, the answer, you don't know how deep you're going already. The thing is, when you are applying a continuous infusion, try to keep the single twitch response between 5 and 10%. For some operations, this is not enough, like if you do aneurysma surgery or something where you absolutely need immobility of the patient. And therefore, we are using only bolus doses as maintenance, because then you see the individual recovery. And once a patient already starts again with spontaneous recovery, you can add some more. But over the years, I've seen, and I've done some studies and published them on continuous infusion requirements. And there is a huge variability. We were testing smokers against non-smokers and obese patients versus, but there is no correlation at all. There might be some obese people needing a lot more than thin ones, smokers less or more. So you can't predict it. And this is again why please don't give continuous infusion unless you monitor it on spontaneous recovery, continuous like 5% or something like that.
Yeah. I think it's continue, Professor, about the reversal. Yeah, this is a question about the reversal agent for neuromuscular blockade. Have to give on every patient.
About reversal, I didn't get it. What is?
Yeah, is the reversal agent for the neuromuscular blockade have to be given to every patient?
No. Well, when you monitor a patient and the patient has spontaneous recovery to TOF 0.95, there is no need to apply anything. Yeah, we divide. We are using only rocuronium in my department, and if we have a deep block and we want to have recovery, we give Sugamadex for those patients, because Sugamadex, the vial is quite expensive. but the minute in the operation room costs around 12 euros in Germany with all the people working there. So the process cost. And if I save like 10 minutes, it's already more money saved in process costs than the vial of Sugamadex costs. Yeah. So because when you give neostigmine, we know that usually from a deep block, it takes you around 25 to 30 minutes to get full recovery on neostigmine and atropine or pyridostigmine. So we are wasting time in the operation room. So this is when we are going for Sugamadex out of a deep block. But if we have already spontaneous recovery, we just give neostigmine and atropine.
Yes. Okay, I think it's clear, Professor Bruno. Thanks. Okay, I think the next question for Dr. Claire. What do you think? Yeah. What do you think?
A couple of questions about opioid use disorder, I think, if you're referring to that. So just probably the easier question, which is what are the side effects of using opioids in the long term? Just to point you again to a very good resource, Opioids Aware, which is the UK website for looking at this, is a very, very good resource. The important thing about opioids in chronic non-cancer pain is that there isn't population-based evidence that they are effective. That's the first most important thing. That there isn't evidence, population basis, that people have improved pain and improved lives. So first of all, there's no, unless for the odd individual they might be helpful, but basically there isn't evidence that they work, but there is evidence that they have side effects, and the side effects that we're all very familiar with, things like respiratory depression, constipation, nausea, or CNS side effects. But there's also some longer term stuff that can affect a lot of the hormonal axes in patients. So it can affect your sex hormones, and you can get a complete Addisonian crisis sometimes from it too. So there's a lot written about this, and there are some long-term effects, and is also the problem of misuse, and of people having addiction problems and diversion of the drugs, so the drugs can get into an illegal market. So those are the broad areas that we tend to talk about. But as I said, it's actually very well documented and researched, so it's very easy to read about that if you're interested in reading further. And the other question is, do I think that EPM will reduce the incidence of opioid use disorder? I'd love to say that it will. I mean, I think there are many things that would need to be done to improve the problems around opioid use disorder. I think education is very important. I wouldn't like to claim that EPM on its own will be able to solve the problem, and whether it will keep increasing or not depends on the much broader system, wider system of initiatives that will be needed. I think, as I keep saying, education is really important because it's a complex issue, and it's not just about having more or less. It's about understanding the complexity of opioids.
Yeah, the next question, Dr. Claire, about the chronic pain, using chronic opioid in chronic pain.
Yeah, so I think I just answered that. So should we be using it regarding its side effects? That's the question I think I answered at the beginning, that there isn't good evidence that it works for chronic pain on a population-based in population-based studies, but there is evidence of harm, and there are many areas in which it can cause harm, both physical, both short-term, long-term, and to society. And as I said, it's very well documented if you want more details.
Yeah. Okay, thank you, Claire. To Professor Rapong, there are two questions for you in the chat box. Is it possible to use perfusion index to evaluate fluid responder in daily anesthesia practice?
Yes, the perfusion index is an easy one and very convenient. The answer is yes, but we have to think that the data is reliable or not, because the perfusion index is a simple one, but it depends on the perfusion to the finger. Like when we have the cold patient, the environment is so cold, the perfusion is not enough. Before we use the PI, perfusion index, the data from the pulse oximeter, we have to make sure that that finger is the highest PI finger. For my study, yes, I collect the data from 100 people, and we see that 97% of the patients show that the ring finger have the highest PI, and we use the ring finger to guide. Or in the beginning, if we see that the index finger is higher, okay, we use this index finger to guide. And then after that, if PI is more than 1%, we can use this one to guide, and we just do the leg elevation or do the full challenge test. If the PI is improved, this is related. But if the PI is nothing happened to the PI, we may think that, okay, fluid may not so good, but the PI is the sensitive one for another factor, like the co-environment or some compression mechanical that cannot improve the perfusion to the finger. But if we sure that the circulation is normal in that situation, nothing changed, and only fluid responsiveness, we can use this one, an easy one. But not only the PI, but I recommend to use another option as well. During the operation, we do the intubation, right? And we can do the lung recruitment therapy, because the lung recruitment therapy is very popular. The one that we have to do in everyday practice. Every time we do the lung recruitment therapy after intubation, and we increase the pressure in the thoracic. If the blood cells fall down, or if we have the stroke volume, the stroke volume fall down, or if we have the SPV, if it changes, or something changed, like the simple one, but it fall down, this relates to the fluid responsiveness. This is the easy one. Or that the another question in this one show that, can we use a tidal volume change to guide, right? Tidal volume change is very, very good one as well, because the trend is we use a low tidal volume. How to use the SPV CPV to guide is we have to maintain stroke volume more than, tidal volume more than 8, right? But the lung process is only 6 to 8. In the beginning, if we use only 6, how can we sure that this is enough to have the lung direction? 6, we have to improve to 8, and we have a loop. Or if in the beginning we use only 4, we have to improve 4 to 6, and we see that if it changes or not. If it changes, this is fluid responsiveness. But if it not change, it means no variation from the heart lung direction. We may think that this is fluid non-responsiveness, right? And another question from the previous question is he asked about the clone Trendelenburg, right? Clone Trendelenburg and clone reverse Trendelenburg. Is it improve the outcome or not, right? We use the clone Trendelenburg, the prone position for the COVID-19 to improve the quality of the ventilation, to optimize the VQ ventilation and perfusion abnormality, right? But when we do the prone position, and how can we evaluate fluid responsiveness, that I recommend that you use the reverse trend and trend Trendelenburg about 13 degrees up and down, right? But I'm not sure this question is meaning that before and after can use for guide. Yes, the answer is yes. But if the question is it improve the quality of lung function? My answer will be that if the Trendelenburg during prone position compared to the reverse Trendelenburg, it depends on the patient. Some patients have the pathology in the upper lung or the lower lung. It depends. So if we try to do the up or down and the lung function or the saturation is improved, it depends on that.
Okay, thank you, Dr. Surapong. I think it's clearly for Dr. Juwita. Professor Pringle, I have a question for you about desfluran combination with opioid like remifentanil or sufentanil. It's better than use only fentanyl in your experience.
Sorry.
Yeah.
No, there is no difference what kind of opioid you're using. The thing is, I'm not a big fan of remifentanil. I do not believe that in anesthesia it really makes sense to have a short-acting opioid running through the operation. And at the end, we start to give like morphine to cover post-operative pain already, half an hour in advance before we end surgery. I really think, again, as a patient, and this is always what I put in relation when I think about how to design my anesthesia, what would I like to have? And the thing is, I would like to be brilliantly awake. I would like to have my full muscle strength and power. I would like to swallow to protect my airway, but I would not like to have pain. And therefore, there is no need to have a short-acting drug within anesthesia. I mean, we are using remifentanil when we do, regional blocks for end atherectomy in the carotid artery when we infiltrate here. Then we use it. We do it for lithotriptic interventions in urology. We do it for sometimes to add a little bit for awake fiber optic intubation. But for general anesthesia, we use fentanyl or sufentanil. And in accordance with desflurane, it doesn't matter which opioid you add. It's the opioid effect is for analgesia, and the sedation is done with desflurane. So there is no optimal combination I would recommend. I in general, I just say I'm not a fan of remifentanil because I do not believe in the philosophy to have a short-acting opioid. And I mean, Claire will add or support when I say we know all about the hyperanalgesic effects post-operatively, which we do not want to have. And therefore, for me, I'm not a fan of Remi. But there's no matter if someone loves it, they should add it. But for me, fentanyl or sufentanil is the drug of choice in combination for desflurane because people are waking up, but they still are pain-free, and that's what I want.
Yeah, because
May I ask?
Okay, Dr. Ray. Yeah, because I asked Professor Pring like that because sometimes we are difficult to have a compares from the very short acting to long-acting opioid after post-operative care. So I a little bit agree for you, Professor Pring. Dr. Claire, you had any comment?
So I actually had a little question, if I may.
Yeah.
Yes.
Okay. Please.
When you talk about using desflurane, I mean, I'm a fan of desflurane for some cases, for very long cases. We're getting a lot of pressure about the environmental effects of desflurane. Yeah. Have you had anything about that?
Well, there are, the most important thing is we have to talk about two things. Yeah. There is no effect of desflurane and sevoflurane on the ozone layer, whereas there is a huge impact on the ozone layer for isoflurane, for enflurane, and nitrous oxide. So we should avoid this in terms of that. There is the discussion is that desflurane has a longer half-life in the atmosphere, and therefore there is an increased greenhouse effect. But if we again take it into relation, and of course I observed this discussion very intense. The thing is, the worldwide production of desflurane is 960 tons. 960 tons, not thousands, not millions. It's 960 tons is the worldwide annual production of desflurane. In combination or in contrast, there is like 380 billion tons of CO2 we are producing. If we put this into relation, this is an Olympic swimming pool, okay? The CO2 production. And it's 10 teaspoons. 10 teaspoons of an Olympic swimming pool is desflurane. And for me, of course, I know that desflurane has probably a little bit worse impact than sevoflurane. But I'm a doctor, and I am responsible for quality and safety in my patients. Okay. And therefore, I'm very sorry to be an ignorant doctor who cares more about the patient rather than about those 10 teaspoons of desflurane in the atmosphere. And this is what I have to say. I know it has a 3 times longer half-life in the atmosphere than SIBO. That's fair. That's right. But I still say the advantage is much better. And the second thing is, when we are using desflurane, we are using it on metabolic flow. So we are having only 200 milliliters of oxygen fresh gas flow per minute. And this is the same thing. As we go down with the flows, with the metabolic flow, with the fresh gas flow, there is less pollution in the air rather than running with 1 liter or 2 liters fresh gas flow. And this is what we do. We reduce the fresh gas flow. We are aware of the fact that our drug is a little bit more impacting global warming or whatever. but 10 teaspoons in correlation to an Olympic swimming pool, I'm very sorry, I'm not afraid, and I don't feel bad and sorry, because I know I do best care for my patients.
Okay, Professor Springer. I think, yeah, there's some reason. Yeah, it's a human reason. It's a very, yeah, it's a humanity reason. It will be make some decision, yeah, to make a Desflurane will be a choice.
Yeah.
Okay, Dr. Surapong, I have a question also for you about the opioid. The same with the Professor Puringer in a hemodynamic parameter. What do you experience about the many kind of opioid that we use to the hemodynamic changing in our patient?
May I express another point of view? I'm the big fan of the remifentanil. But
yeah.
I use a lot of remifentanil when I was in Belgium. But when I back to Thailand, remifentanil is not available in Thailand. We cannot use this one. Because why remifentanil is very good, it helps us to optimize hemodynamics for the short stimulation. For example, in the sternotomy, when the surgeon do some short stimulation, if we use a lot of opioid in that time, it's too much for, it's optimum in that time, but it's too much for the an hour after that, it's too much, we have hypotension. But if we increase the remifentanil, the stimulation will be 5 minutes and the remi will be only 5 minutes, going up and down in the same time. But after we don't have this one, we develop the opioid-free anesthesia by facilitate our Thai population to use the regional nerve block. Right now, the selective nerve block is very popular. For example, for the cardiac surgery, we can use the ESP nerve block. We can use another many technology. And for the orthopedics or abdominal, we just combine. Right now in Thailand, almost more than 50% of the case, we combine the regional nerve block in almost every case, if we can use it, and we can reduce the opioid. But the quality of the awakening is very good, and it can wake up clear together with the Desflurane and together with any kind of the anesthesia.
Yeah, okay, thank you. I think the opioid sparing strategy, our opioid sparing strategy now increasing our using of the nerve block or other methods there. Okay, I think there is no more question in the chat box. We have about 5 minutes, so I think that I will better use it for you. I cannot complete all our discussion and also your presentation, but let me ask you about the short conclusion for your presentation to take home message for all the audience. We start for Professor Springer.
Well, as I summarized in my presentation, I think we should try to use predictable and reliable drugs. We should try to, at the end of anesthesia, to provide fully awake patients, because this protects from respiratory depression, this protects from aspiration, and this is, I think, what is most important. The perioperative phase initially is endangered by hypoxemia, and all the protection a patient receives himself after the end of anesthesia to protect from hypoxemia are of utmost importance. And this is what we can provide when we are using short-term drugs, when we are using quantitative neuromuscular monitor, whenever we add a muscle relaxant. And this is what I'm asking for, to give the patient the chance to recover fully himself, to receive his vital functions again.
Thank you, Professor Purin. Professor Surapong, you have any short conclusion for the take-home message for the audience?
My take-home message is every time in the daily practice is when we say the patient, why not we just focus what is the change? Sometimes it's difficult to remember what is parameter, or to remember if this one is enough or not. Why not we just have a look before and after we change? For example, if we would like to change 500 amount of the fluid, we just give 100 and have a look at the trend change before and after change. If it is the right way, we just give more and more. We don't have to give 500 and give the diuretic because it's too much.
Thanks, Professor Surapong. Dr. Claire?
Thank you. So I'd say that opioids are both fantastically useful drugs, but they can also cause a lot of harm. And I think it can be quite difficult sometimes for us to hold both those two things together. But I think it's important to understand that they can be both very helpful and very harmful, and it depends on the context. And therefore, education is an extremely important part of understanding how best to improve analgesia, because we need to both use more opioids in some circumstances and less in others.
Yeah. Okay, thanks, Dr. Claire. So I think that we are arrived in the end of our session. I would like to say thank you very much for your really time, for the participate in our international webinar. Special Professor Springer and Dr. Claire, you have to on air in the early morning. But I really appreciate, and also the others, of course, really get many information from all of you, also from Dr. Surapong. There is a very good informative and informative presentation, and I think all the audience will be agree that very big time for all of you. Thank you very much. And also for the audience, thanks for your participation in this webinar. I hope that we can meet, maybe in reality, not online again, but in offline. Come to Indonesia. Dr. Claire, Professor Springer, and Surapong. Thank you very much. Bye-bye.
Thank you very much. Thanks for
very
the
much.
Thank you. Stay safe.
Yeah, stay safe and stay healthy. Okay, I will be back to the MC, Dr. Haisa, to end the session.
Yes, baik. Terima kasih Dr. Takdir Musbah. Dengan selesainya pemaparan dan diskusi kita siang ini, maka selesai pula rangkaian acara webinar online kita pada siang ini. I would like to thank to all of our distinguished speakers who have shared their knowledge this afternoon local time. It's an honor to have you all at this online webinar. Thanks to Professor Puringer, Dr. Claire Rose, and Dr. Surapong Larsomradi. Thank you. And also thanks to our moderator today, Dr. Takdir Musbah, who has led the discussion with a very interesting discussion. Dan terima kasih kepada WR2 Profesor Sumbangan Baja, Ketua Kati Prof. Rita, dan Ketua Departemen Ilmu Anestesi FK Unhas, Dr. Safruddin Gaus, yang telah membuka acara ini. Terima kasih kepada para guru besar Departemen Ilmu Anestesi FK Unhas, Profesor Husni Tandra, Profesor Muhammad Ramli, Prof. Safri, kepada seluruh staf, pada seluruh partisipan yang telah meluangkan waktu mengikuti webinar ini. Terkhusus kepada sponsor kita pada acara siang ini, yaitu Mahakam Beta Pharma. Terima kasih atas dukungannya untuk acara ini sehingga acara kita terlaksana sesuai rencana. Terakhir, terima kasih kepada panitia, Dr. Takdir, Dr. Andi Adil, Sekretariat dan Admin, Departemen Ilmu Anestesi, serta para residen yang terlibat dalam pengaturan jalannya acara sehingga acara dapat berjalan lancar. Semoga acara ini bermanfaat bagi kita semua. Wassalamualaikum, selamat sore, good afternoon all. Thank you. Terima kasih.
Terima kasih Dr. Reza, Dr. Takdir.
Terima kasih,
Dr. Reza, Dr. Takdir. Assalamualaikum. Waalaikumsalam.
Terima kasih.
Sudah boleh kita meninggalkan ini, Dr. Aisyah?
Ya, silakan dokter. Terima kasih, Dok.
Ya, makasih.
Izin live juga. Terima kasih dokter semua.
Terima kasih.
izin lead Prof. Saya izin lead